Hello Instafam, it is Dr. T here on a very dark and stormy night here in Perth. So I have just bundled the kids off to bed. I thought I would jump on, better late than never. I hope you guys are all well. Well, I think I have finally gotten over my jet lag. I've got to tell you, it's taken me a couple of days. It's always harder, I reckon, on the way back from Europe than going there. I always feel fabulous. Maybe it's because I'm so excited, the adrenaline's running, I'm in a new place. But when I get back home again, oh my goodness, it takes me ages. How are you guys? Hello. I can see there are lots of my beautiful patients online, and I just want to let you guys know I am watching. Don't you worry, I am paying attention, and I just want to tell you, keep going. Everybody is doing super well. Okay, well, where have I been? I have been at ESHRE. ESHRE this is the first time, can you believe it? I have always been the one left behind to do the egg collections, but this year was my year to go to ESHRE. So ESHRE stands for the European Society of Human Reproduction and Embryology. It is the biggest fertility conference in Europe. Some 11,000 people attend this conference from all around the world, obviously all of the European nations, but there's a large contingent that comes from China. Not a lot of people from America because they got their own big conference, but some, definitely people from Japan, India, and of course Southeast Asia, and Australians. Large contingent of Australians there. It is amazing. And I learned some really cool stuff. I met some really unbelievable people, and I had a couple of incredible opportunities. So I'll tell you all about it as the days roll on. But remember, we are on here for Q&A. So if you would like to drop your questions into the comment section below, couple of guidelines around questions, guys. Please make them short and sweet. Try and make them as generic as possible. Don't need your whole life story. I will not be answering anyone's personal medical history here. And this is not the place for personal medical advice. Let's face it, social media is not the place for that. But I am giving you some of my time I like a chat, and I like to talk about the things that I do. So if there is a burning question that you got, drop it in the chat below, and I will attempt to give you a nice, succinct, generic answer, which I'm not very good at succinct or generic, but I will do my best. Remembering, of course, that you should always go and seek your own medical advice, and a lot of this is opinion-based, but with a tinge of evidence to it as well, because that's what I am, an evidence-based medical practitioner. Okay, so while I've been gabbering on, I'm hoping somebody is typing away and dropping some questions into our chat. Thank you for joining me. So whilst we're waiting for some questions to be dropped in, let me tell you a few great facts that I learned at ESHRE. There are actually more than one type of isoform or copy of follicle stimulating hormone, which is one of the hormones produced by your pituitary gland that stimulates your ovary, and it is also we give you in IVF and in ovulation induction, we give you the recombinant version of FSH, one of the common ones. Oh, Jess, I'll answer your second question in a sec. But one of the common ones is Gonal F, Puragon, those kind of drugs we give you in our stimulated cycles. Now, get this, there are more than one isoforms of FSH. In fact, there is one called FSH21 and one called FSH24. And can you believe it? FSH21 is produced by young women, whereas FSH24 is produced by older women. And there was an incredible woman, Professor Francesca Duncan from the US. I had the opportunity to present alongside her, and she presented her data of work she had been doing in a mouse model to show that FSH21 is actually the FSH that promotes better egg quality, it promotes better fertilization of eggs, it promotes better blastocyst and embryo development, and it is associated with higher pregnancy rates. So this could be like the Holy Grail. This could be what we're looking for, that in fact the products that we should be creating to stimulate are not based on sort of the urine of postmenopausal women, but the FSH of much younger women. And it also begs the question that perhaps this is one of the reasons why older women struggle to conceive. Maybe it's not all just about chromosomal abnormality and problems with the mitochondria, but it might even be about the type of FSH that your brain is producing to stimulate your ovaries. So I had one of those mind-blowing moments, and I can't wait to continue to watch the work that Professor Duncan is doing in the US around FSH21 and FSH24. Blow your mind. All right, I've seen some questions. Jess Maury, thank you, my dear. How is the puppy? So the puppy is now coming up 20 kilos. He's about 8 or 9 months, and I can't use those words on social media, but chaotic nutbag would be the case. So what I've learned is enrichment. I have to exhaust his mind as much as I exhaust his body. So Timu just got a thrashing from me tonight, and there are a whole heap of enrichment tools coming my way. Amelia Clare, mild adeno, IVF implantation failure, received 2 opinion. One says yes, you do. Okay. Here's what I learned at the recent ESHRE conference. In fact, adenomyosis might be a bigger impact factor on implantation failure than endometriosis. Get that? So there is a lot of work being done on adenomyosis and embryo quality and implantation factors right now, and I think we need to give it the respect that it deserves. There is emerging but strong evidence to suggest that downregulation of adenomyosis with hormones, again, protocols aren't really clear, but rule of thumb, a good 3 months of really shutting down that disease is going to improve ongoing pregnancy rates, implantation rates. So yeah, we think that working on adenomyosis is really, really important. So the big question remains, what degree of adenomyosis is important? On your ultrasound reports, you'll see a mild diffuse, you'll see severe, you'll see focal. Which type of adenomyosis is the most relevant from a fertility point of view? That is still being worked out. Is it women who might have extensive disease but be asymptomatic versus women who have extensive disease but are symptomatic? Like, is it that important? Or is it the radiological appearance? So those things aren't really clear, but I certainly think if we've got a woman who's presenting with recurrent implantation failure and they have adenomyosis of a decent severity that you can see it on radiology and it's probably causing symptoms, I don't see that downregulation is going to do you any harm, and it may actually be the answer to your problem. Staffy Mama Me, would PGTA testing ever be done on already frozen embryos? Yes, that happens. Does it increase the risk of losing embryos at transfer? So the issue with biopsy of an embryo that's been frozen is that you then have to freeze it again in order to wait for the results. So really the issue isn't the biopsying of an embryo that's been thawed from freezing. It's the fact that you've got to refreeze that for the second time. And there is some data to suggest that twice frozen embryos may not have the equivalent pregnancy rates that a once frozen embryo does. It probably also impacts on the lab as well. Certainly in my lab, we have twice frozen embryos and our pregnancy rates are no different, whether they've been twice frozen or once frozen. And this is using embryos that aren't necessarily tested. So you've got to think about that as well. But overall, because you freeze embryos for lots of different things, right? You freeze them because someone got OHSS, or perhaps they had an early luteinization. The progesterone went up before the egg collection. So there's lots of reasons to freeze, and there may be other reasons to twice freeze. So for example, you might thaw out a frozen embryo at an embryo transfer, and oh my goodness, you can't get through the cervix, so you have to refreeze that embryo again. So you've really got to compare apples to apples and pears to pears. So if we are talking about PGTA tested embryos, so they're all embryos that are therefore going to be chromosomally normal, that are transferred, there is, as I said, some data to suggest they may not be as robust. How big a difference that is, I can't tell you off the top of my head, but I do think it comes down to, well, how good is your lab? So it's a great question to ask your lab, okay? Jackie Lamb plug. Hi, do you recommend SOERM? Do I recommend sperm? Can you come back to me and clarify that question again? Amarinia, hi, is there a higher chance of birth defects with ICSI compared to IVF? Great question. So, there is registry-based data, so that's where we go, who are the people who had IVF, and look at it over a period of time, and then of those people who had IVF, who had birth defects. And so you like compare and contrast. There's no prospective cohort studies, good quality studies. It's just sort of registry-based data. So there could potentially be some confounders in there. But the long and the short of it is that babies born from IVF are thought to, assisted reproduction, which includes IVF and ICSI, do have a slightly higher risk of congenital anomalies. So these are things like cleft lip, hole in the heart, renal abnormality, anatomical things that are fixable, not things like syndromes. So it is a slightly high risk, though the absolute risk is still really low. So if the background population is 2%, then in an IVF ICSI population, it's about 4%. So the absolute risk is still really low. And we do believe that is marginally higher in an ICSI population. But here's the thing to remember, that people are getting ICSI done for a specific reason. Often it's due to male factor or failed fertilisation, or perhaps they're having testing and so they need to have ICSI done. So they are a different population to those doing IVF. So is it the technique that we're using, or is it the population themselves? And I think that's a really important question that has not been answered. So hopefully that just sheds a bit of light. Justine Proctor, hello my friend. Hi Dr. T, any updates from the conference on supplements? Anything about NMN? Well, not at this conference, Justine. However, I did go to a meeting earlier this year. Where was it now? Sydney, Melbourne, I can't remember now. But there was a presentation by a basic scientist, so someone who was doing work in an animal model, looking at NMN and NAD, or nicotinamide. So NMN is the precursor. So it's kind of the same thing, really. And I'm trying to get the exact wording right here. The long and the short of the data that was presented is that although biologically it sounds plausible that this chemical has a role in preventing cellular breakdown and cellular death, and so therefore might help with egg rejuvenation, it also actually has a really important role in ensuring that abnormal cells die. So we call that autophagy. And so if we give NMN NAD, we are preventing autophagy, or breakdown of dead cells, or damaged cells, I should say. What that could potentially mean is that we're preventing the breakdown of cells in the body that really should break down, i.e. cancer cells. And so the big take-home message that I got from the lecture, which made me sit up and take notice, was number one, we don't have any really good data in humans to show this stuff works. In fact, the data in animals isn't clear. But more importantly, we can't say that this is safe. And the big thing that I want you guys to hear from me on this is just because something is a supplement, i.e. found in nature, made from plants, made from sort of organic materials, does not always mean that it is safe, okay? So I'm second guessing right now the data on NMN and NAD, and as I said, there's no good data in humans, there's questionable data in animals, and maybe we might be preventing the breakdown of cells that really should break down, i.e. cancer cells. So be mindful of that when you're thinking about taking it. I'm not really recommending it anymore because of that. Rollaby, did our lady talking about sperm come back to us? Hang on, Rollaby. Oh, there's a few other questions I might have missed. Oh, Jackie. Hi, do you recommend sperm DNA fragmentation for men? I do. I think it is a really good counselling tool for men. I think the one area that none of us do particularly well is talk to men about their own fertility and how the choices that they make impact on their sperm health. Sperm is a great barometer for a bloke's health. And if I've got a bloke who is sitting in front of me, who sits in a truck all day, is obese, is a smoker and drinks 20 cans on the weekend, you better believe I'm going to do a sperm DNA test on him, because if his DNA fragmentation is high, which it probably is going to be, I've got a really great opportunity to talk to him about reducing all of those toxins. So I definitely do sperm DNA fragmentation for men. Some people would suggest that, and you would see it in the international guidelines, that it's not a recommended first-line test. But you actually have to do a semen analysis to do it. So if you do a semen analysis and it comes back abnormal, then you've got to do another one to do the sperm DNA testing. So I do it on the first opportunity that I have, because it prevents from doing too many tests. Is that FSH21 readily available? No, Jess, it's not. This is all in research stage and it's still in animal models. Don't you worry, my friend. As soon as we've got our hands on some recombinant FSH21, I'll be using it. After it's had some good, appropriate therapeutic randomized control trials done on it. Okay, and V, what's the FET process after a successful pregnancy and a year off? Do you just jump straight into a FET or need to do testing prior? We would always do infectious diseases testing, absolutely. That's really important. Probably don't need to do any male fertility testing on your partner because we've already got the embryo. I would probably be suggesting, congratulations on the pregnancy. I take the stance not to be breastfeeding whilst doing a FET, though there is some data out of Repromed in South Australia to suggest that perhaps we can quite safely do a frozen embryo transfer whilst a woman is still breastfeeding and get good pregnancy rates. Not good quality published data as yet, so I would prefer somebody not to be breastfeeding. But another thing that's important is to do the pelvic ultrasound. So particularly if someone's had a caesarean delivery, but you don't want to come across a polyp or a fibroid that might have developed in a short period of time that is going to impact on your ability for that embryo to stick. So a pelvic ultrasound is really important. Infectious diseases screening, endocrinology, looking at things like your prolactin levels, looking at your thyroid function, sugar tests, and anything else relevant prior to starting a cycle. So hopefully that's helpful to know what you need to do. Okay, Laura Jane 89. Oh, the questions are rolling in now. Hi, what levels of progesterone are optimal in early pregnancy to ensure viability? Are pessaries beneficial? Well, that's a loaded question, Laura Jane. In a natural cycle, a progesterone of somewhere between 30 to 50 is probably normal in a normal pregnancy, but a lot of us kind of take a bit of a belts and braces approach in that we want to ensure that there's a lot of progesterone around. So pessaries are thought to be beneficial, particularly in IVF cycles, because we are stripping the follicles of the cells that produce progesterone. So, and some people are progesterone deficient, or they have a lining where the progesterone receptors are defective in some way. Like we know women with endometriosis, their progesterone receptors are probably a little abnormal, hence why they've got endometriosis. So it really depends on what sort of transfer cycle, whether it's a fresh, whether it's a frozen, whether it's a low-dose stimulation, whether it's an HRT. Difficult question to answer, but progesterone is important. But please, what I would recommend, don't go chasing numbers. Don't bug your fertility specialist because your progesterone one day is 55 and the next day it's 52. Listen to your specialist on that one. Tamarin, would you recommend a 38-year-old to use donated eggs? That's a really difficult question. If she's got enough of her own, I would use her own. If she doesn't have any of her own, she might need donated eggs. Difficult question to answer, but I don't see any harm in using donated eggs if you don't have any of your own. Because there are some 38-year-olds who go into menopause. Hello, Monique, Donatelli, Danielle, Rachel. The questions. Rollerbee, I've come back to you. What are the best questions to ask your doctor before implantation to ensure your body is ready for it, and what kind of blood test do you recommend? Could spend a whole night talking on this. Body is ready for it. Well, you definitely need to be on folic acid. You definitely need to have not been smoking and probably minimally drinking. You definitely need to have watched your weight. You should really be aiming for a Mediterranean-style diet and moderate levels of physical activity. They're the sorts of things that you can do. Obviously, have a good pelvic ultrasound. Implantation. Well, I mean, I guess it depends on what the issue is. I mean, if you're just talking about pregnancy, then you need to do all your antenatal blood screens. Definitely consider carrier screening. That's genetic carrier screening. That's really important. Yeah, it's a hard one to answer when I kind of don't know the clinical context, but hopefully some of those tips are helpful. Carly, Sarah, okay. If a euploid embryo fails to implant when you're well and lining looks good, should you push for additional testing before another transfer? If that is your first euploid embryo transferred ever, just transfer another one first. Yeah, that would be my recommendation. I'm glad you're enjoying my live. Hello, Sophie, Meg, Laura Jane. Glad that was helpful. Guys, I reckon I'm done. I think my brains are spewing out of my ears. Thank you so much for those challenging questions tonight. It has made me think. Over the next couple of weeks, I am going to be talking about a few more things that I learned at the conference, which will certainly be interesting to everybody. And don't forget, next Tuesday, we have our live on Charlie Health. And we are going to be talking all about hormone dominance. Let's talk about estrogen dominance. Let's talk about progesterone dominance. All of that stuff that I get in my consult room, I'm going to talk about with my dear friend Sam, who is one of the nurses behind Charlie Health. We are going to be talking on Tuesday evening. You should be able to see the advertisement in the feed. I hope you guys can join us. If not, you will be able to catch up on the live that we do later. Have a good rest of your week. Hopefully I see you soon. And to all of my beautiful patients who have got on here, see you soon.